afternoon. Thank you for joining us over your lunch. I appreciate this is your lunch hour, so we very much appreciate your attendance at this lovely symposium. It's such a pleasure to see so many people back here in the flesh. I'm sure like many of you have been looking at small pixelated screens for the last 2 years, and it's brilliant to have people back at an educational forum like the World Union and have opportunities to share insights like this. I think it's so good to have that connection back and that energy back in the room. So really appreciate you all joining us today. I hope we've got some great insights to share with you today. We've got excellent faculty here to talk about surgical site complications. So I'm really delighted to say we've got Professor Thomas Pavasic with us. Thomas is Head of Department of General Surgery and also Director of the Institute of Surgery at Poznan University of Medical Sciences in Poland. And I'm sure many of you may have seen publications from that department and from Professor. It's a department that's very experienced in the use of negative pressure wound therapy and surgical incisions. I'm delighted that they'll be able to share some of his insights today. We've also got Dr. Gareth Irwin with us here today from Belfast. Gareth is a oncoplastic breast surgeon in Belfast, in Northern Ireland, and he's also an honorary lecturer at Queen's University in Belfast, and again has excellent first-hand experience of using single-use negative pressure wound therapy in the management of breast surgery today. So I hope you're going to take some insights away from this and some new education around the use of single-use negative pressure wound therapy. And with that, delighted to hand over to Thomas, our first presentation today.
Thank you very much. I'm very happy to be here and share with some experience in an area which is still a really huge problem. I'm a colorectal surgeon, so for us, cervical site infection is a big problem, and it's really very common situation. So the disclaimer, as you probably know, the session is done by this meeting. And I think we're still in the moment in which cervical site infection happened, and we are a little bit surprised and we think what to do in the situation. It's like to have a car accident and then think, in this situation, how to learn safety drive rules. For this one situation, it's a little bit too late. Of course, we need to do that, but our crucial point should be how to know previously how to avoid this situation. So, what is our topic? And I think, I hope we'll show you in my presentation. It's the idea how to prevent cervical site infection by strategy, by your head, by your really smart thinking, by devices, and also by standard institutions. So we know very well that early detection of cervical site infection is crucial because it's the process. This process going from superficial tissue deeper and deeper, and if we don't stop it, we will have a really severe problem with patient. And the cervical site infection is the moment during the therapy. It's not the start of the problem, it's not the finish. We are between different stages of treatment of patient, intraoperative, preoperative, postoperative, and everyone is important because nearly always it starts from the small problems. It should be in many cases just treat as nothing serious happened. And then we learn that something serious happened. I will not talk about the frequency about the overall hard data. I want to talk more about the results of cervical site infection, of implication of our daily practice, how we know the problem exists in really huge number of patients. This, I think, is still not very interesting for surgeons because it's so ordinary and so common, it's nothing special. But if you imagine that the number of patients dying all over the world every day, it's like 6 big airplanes was crashed. And I think every agency will talk about it really 24 hours, and every day we lose so many patients because of cervical site infection as the only reason of death. So maybe we like cervical site infection. Maybe it's good for hospital for us. Unfortunately or fortunately, no, it's not good for us as a surgeon, as a medical staff, as a nurse, because it's in every situation make our treatment more complicated, more expensive, more frustrating. I think it's still an undiscovered area. If you are a nurse, if you are a surgeon, and you have a problem with wound healing, all the results of your surgical treatments are gone because the patient is not happy. The patient is sleeping. If you operate the patient don't know what was happening inside. You can make a beautiful operation, you can remove the cancer, but the patient will be frustrated because the wound doesn't heal, the wound heals, the exudation is purulent, and for example, the chemotherapy is not started because we have surgical side infection. So it's not only discomfort or the worse healing, it's a really dramatic for some patients situation, making his life sometimes in oncological patient extraordinary. We need to remember about it. That's an example of surgical side infection. I worked in department specialists, we can call specialists in admission of complicated patients in different settings. So in many cases we admit the patient in this stage like this one, the patient with a better general condition, with kidney insufficiency, with septic condition, and of course with surgical side infection, very deep one, that's a 4-degree deep organ penetration, but it's not the biggest problem of the patient because the patient is very close to die because of surgical side infection. So how to do? What to do in this case? Of course, treat the patient. Of course, make all the stages, or making the wound more clean, or wash them. Then use negative pressure wound therapy. Then start to make a wound more clean, remove contaminated tissue, make instillation, making the tissue connected together. I think it's another problem, and we still don't take enough our care about this, how to connect the tissue. Negative pressure wound therapy is a great solution to don't make a huge wound. You can see how many different strategies we have just to make a wound less open. I like very much the very simple, very cheap kinesiotherapy. They make the wound more squeezed. But negative pressure wound therapy was a point for this patient. And what I want to show that day by day, in this case, using some multiple procedures, using some operation, we improve the situation, we improve general condition of patient. After a few weeks, we decide to make a refreshment of the wound. We decide to close the intestinal fistula. We decide to close the tissue above the fistula with a really high tension of the tissue. It's generally contraindicated, but sometimes you need to choose the only one decision, only one strategy. Then, as you can see, we like to make a prevention of wound complications in both situations, in clean wounds as well as in the contaminated wounds, because we have a different level of prevention. We will talk about it later. And let's look at the final situation. That's healing. Is it very good? No, it isn't. It is hernia pain, but it's not fistula. The patient survives. The patient can have enteral nutrition. So it's so. When we think about the standpoint, we should be happy. But when we think deeper about the situation, the question should be done, why it happened? That's always for us the start point to improve our strategy. And we will take organization talk about surgical infection, and you can see how many factors influence on surgical infection. I don't want to make a point by point because you can easily find it in all documents of the root health organization. But if you can see, they concentrate on preoperative, intraoperative, and postoperative health. And the negative pressure wound therapy is one of the methods which is recognized as effective in this situation. But what I'm talking about, because this patient, before first operation, it was elective procedure because of abdominal hernia. The patient has time to prepare, the surgeon has time to prepare. And let's look what is possible to do. The patient can have normalized glycemic diabetes. The patient should have antibiotic prophylaxis. The patient should be informed about stop smoking and about results or complications after the smoking. Rehabilitation for the patient. Botox injection will make the tissue more relaxed. Negative pressure wound therapy, single use as a prevention of the incision line after the surgery. Information for patient after complications. And nutrition preparation. What happened in this case when we asked the patient? Only antibiotic prophylaxis was done. Let's look how many possibilities we lose in these cases because of no time, no strategy, no decision, no talk with patient, no involve the patient into therapy, and no active strategy. So we don't should wait for surgical infection. we should avoid it, but not because of trying or just thinking positive, but because of our real practices. And maybe we can ask about the cost. Maybe it's very expensive. When you make a cost comparison for every level of this point, it's really not so very expensive. Especially when you compare with the results of the treatment of this patient. They are priced for Poland, so they are very low. If you have the patient treated in States, you will be having 130,000 euros or dollars. And the prevention cost for this patient was much, much less. So why is it important? Because we need to decide about prevention strategy based on the effectiveness and use the prevention in 450 patients will be cost effective just to prevent only one complication, only 2% of complication. So that's the reason why prevention of cervical infection is so important. And of course we know, once again, we have a lot of data. I think we have data, we trust the data, but we don't use the data because it's still not standard procedure in our hospitals. We know that everything starts much before incision. When you make an incision for the patient, you should be ready for what will happen after the operation. You should suspect, is the cervical infection very common or can happen very common in this situation or not? You need to have in your mind, closing the patient, closing the skin, what type of dressing to do, not because what time you have in the operation room, but which one you decide to take before you make the incision. There are some points to do. They are of course points connected with every stage of preparation. What is important, there are some points, some crucial points about standardization, about teamwork. I think a teamwork, of course every country has different specialties, different situations. In Poland we learn how to work between nurses and between surgeons. I think it's still a big job, and this has a lot to do, and as well in general situation, as well as in the wound treatment. Antibiotic, but the correct use of antibiotics. We know it's a problem. We trust still in antibiotics. We trust that in case of complication we can use antibiotics. Let's look at the resistance of antibiotics. Year by year, antibiotics are less effective. So what is the method? How can we improve? Use antibiotic not so commonly. We need to reduce the surgical site infection by different methods, not by treatment of advanced situation. Of course, there are costs in all the world, and we can check that every level of country, low or high economical level, can increase the cost of treatment. They make the treatment very expensive, and that's the reason we're talking about the burden of cervical site complication or infection. We need to talk about prevention. The prevention starts before we admit the patient to hospital. It's not place to talk about it tomorrow. But I trust that we remember that 55% of surgical site infections are preventable. 55%. Every single patient can be prevented from cervical site infection because of, for example, good preparation before the surgery, nutrition, physical exercises, stop smoking, and psychological support. We started in my department some program. I'm very proud of this program. We make the patient some book of information. That's the problem. The problem that when we operate the patient, always after operation, always after surgery, is the vital time, the catabolic reaction is going down, the condition of patient decreases, and the risk of cervical site infection is higher. But if you improve the condition of patient before the surgery, there is again the jump down, but the level is much higher. So we avoid about 20-25% of cervical site infection. So prevention is better than treatment. But the question is, when to be especially careful in prevention? What type of patient is very suspected to have cervical infection? Should we ask magic ball or something like that? No, we have some scores. We can recognize the patient. Don't worry about so many indicators. Using computers, we still have every year better algorithms to recognize the patient automatically. Finally, you can have the data when you put the patient in the hospital, the red point. Be careful, the risk of cervical infection is much higher than normal. We have two parameters, and the score is relatively high. Let's look at a very simple, I like this score. It's an algorithm that's been designed for people. So single-use negative wound, the therapy device, and look how simple is it. if patient is really risky for surgical side infection, and the risk, especially in bone infection, diabetic infection, obese infection, can lead to very serious surgical infection, prevent it more. Don't wait for catastrophic active prevention. And we know that single-use negative pressure wound therapy, it's effective. It is calculated by economy, especially in high-risk group patients. That's our target, recognize the high-risk patient, and then make the strategy to reduce the complication. And the strategy is based on few levels. In the next presentation, we have a pleasure to show you what happens when we don't avoid this infection in good time. So the difference is pretty nice because it gives us possibility. I very like the method which called surgical wound doesn't see surgical work. What does it mean? We make a wound dressing in operation room, then we send the patient to work, and during the next few days, we don't remove the wound dressing. If you have a people of single-use negative pressure wound therapy or just dedicated wound dressing, we can do that. We can keep the dressing a few days, and in ERA's protocol, we can discharge the patient with wound dressing, and the wound dressing can be removed outside the hospital. Why is it important? Because we have all the time separation between wound and external environment. So no infection inside, as well as no infection from wound outside. We just make something like a separation of the wound, like the isolation of the wound from external environment. And it's very simple to do, and it's very effective. Let's look after the stomach closure. In my department, it's standard procedure to put the pick on above the wound. Let's look how nice we can connect the tissue together, and tissue is the future is only to stabilize the skin. Let's look on the condition of tissue in this potentially septic wound, because the stomach closure means that the stool was connected with the wound. Another example, the patient, obese patient with exudation. Remember, let's think what will happen if we leave this exudation inside. It can lead to hematoma. Then the abscess is very common in this situation. So removing it outside is the best method of prevention. So we have another confirmation that's not work. There is an animal study in which we see that infection rate is much lower in pigs, in rats treated by negative pressure wound therapy, and control on the quality of scare. That's a well-done scare, really nice, and that's a whole regulated scare. I think everyone wants it will be the patient having a scare like this one, and I think it's important. Another factor, avoiding edema in the tissue, squeezing. Squeezing is really fantastic, squeezing a lot. Like you can see other examples with headaches. But you need to remember that the people have very similar effect. Make a tissue connected, not superficially, but make it in the deeper level. It means no fluid edema in the tissue, and then too much fluid, too much edema is a start point to bacterial contamination. It's very good. It's like a test soup for the bacteria. So that's a reason why we look for the effectiveness of phytotherapy. We have also less wound sensitivity for patients, and in well-done group with indication for negative pressure wound therapy as a prevention of surgical consultation, we have well-done study on clinical war. Let's look at this result. One of the center reducing the surgical infection 2.5 to 0. It's really dramatic, improving on situation of patient after it's very execution, but looks on the money, which can be collected for better treatment for our patient or for the staff, just using a simple device. But once again, the device starts to look great. If you know about how to use and why to use, you will do it. So, different levels and different lights. So let's do the green one, so different. Then the yellow one means stable. Because there are other situations when we have a surgical site complication, don't wait. Don't tell that it's happened, I'm unlucky, patient is unlucky. No, let's stop it on this level, because always can be worse. Next day can be worse for the patient and for you. And it can come to the last stage, it's been treated. But trying to avoid a very dramatic treatment. It's much better to have something that's called very bony surgery. It means we have nothing special to do after operation, because we will still do very well. And based on our strategy with the clinician, to suspect surgical side complications or infections. They probably exist. Let's look at an example. Maybe let's first know the really big influence on surgical site infection on our surgical situation that we know about it. There is also much worse for the patient from the long-term perspective, not only based on the situation in hospital, and everything together make a worse situation on the ward. Surgical ward, having a high number of surgical site infection, is the ward of danger for the next patient, is the ward uneffective economically, and this is also the space which is not very comfortable for staff. But what is good? It means that for patient with recurrent surgical site infection or next place on the body of surgical site infection, the rate is much higher. So we can have a second level of prevention. When we have a nice healing of the main wound, but the wound after abdominal fistula, intestinal fistula, and crocolitis patient looks like this one, it means that we have not this space for surgical site infection, but the surgical site infection starts here. And we have surgical site infection. It's a first degree. What we can do? We can just avoid it. That's all. Not the main incision line, because this one is pretty well done. The secondary incision, that's the barrier that is treated by, like you see, the green line is a very optimistic one. So it's very important that we should think how to reduce the cost. How to do it with a simple method, and we cannot be too proud when we treat our complications, and we have very interesting cases. We should be proud to prevent the complication. That's our strategy. And an example, this patient population a few weeks ago with very multiple abscesses and fistula, the operation with very high risk of cervical infection. What we do in this patient on the operation room in septic condition, we put what is interesting. The measurement temperature of the patient is a future. The future is control the situation inside the wound and detection what can happen in the next days. I like the future, what we do today. And then that's a method what we do. Let's look at how to make a negative pressure ultrasound that we address simple, effective, ready to move the patient back to the ward, and the patient is free over from the infection from the bacteria. That's an example what we can observe. Measurement of temperature, that's the early stages of septic condition of the wound. And that is a normal healing. Am I proud about the situation? No. Look what we observed during our study. That's the temperature of the patient after surgery is too low. That's the temperature of the body of patient. Now we have the data that we make a big mistake because the temperature of the body is too low, and then it's pretty normalized. And that is like this one. So good can, but we still put the data. We improve the method of making the patient more heat during the surgery, avoiding the hypothermia. And that's the 4 days after another wound is smaller, and the healing is really very good. You can see the skin around, and the patient will be discharged 5 days later. It's especially important now. The COVID is slowly going, I hope, it's going to finish. But we need to know that this special situation showing us that we need to be more effective because we never know what will happen in the future. And we know that the wounds healing worse of the COVID patient, COVID make the wound healing worse. What is the conclusion from this situation? That we should try to do everything to send the patient home as soon as possible. And it is really important to do it. We need to change our strategy. We need to have a better home care in this patient. We have a devices. We have a paramedical devices. It is good to remember that World Health Organization gives for us the duty to observe the wound 30 days after discharge. To do that, I think nearly normally we do, because it's a huge problem when we discharge the patient. If everything is okay, the patient don't contact with us. If something is worse or bad, the patient sometimes is trying to find another solution. That's an example. What we can do, telemedical system. Our patient during COVID had the application in which the patient can stay in touch, and we have a 18 months 30 days observation, and we recognize about 15% of late surgical self-infection after discharge of patient. and we can make a very fast reaction in this situation. Very interesting problem. So remember that talking about self-say attention and mark self-say application. At the beginning, there is no complicated rule. At the beginning, it's just a rule, and we can do a lot to avoid it. We can make the real influence just to make a rule feel better. Do we have audio? Maybe it's my son. My son is 9 years old, and he asked me how to make presentation more interesting.
And so smile, and round softly smile. Imagine healthy people and no exercise.
So it's very imagine that we can do that. And we can do it. Because we have tools, we have devices to do it. So it's very important.
What a stage is set now. He's brought his own musical accompaniment. That's incredible. So congratulations to you and your family for making that brilliant video. Next I'd like to invite our second speaker on stage, Mr. Gareth Irwin, who will talk to you about the use of eco single-use negative pressure across the network. Thank you, Gareth. I feel I need to say my presentation really after that. Thomas has helped make sure you some horrific wounds, but what we're trying to do in breast surgery is think about reducing the risks of any complication to start off with. Just in schools, pain consultant, what's left about healing. Sometimes there are moments in life which are sort of paradigm shifting. What happened was this is Halstead who undertook a Halstead mastectomy. And the reality was that in the late 1800s, this was a moment that defined breast surgery for the next century. The interesting thing was at that stage of breast cancer, there was 5 years survival of like 40%, so the treatment wasn't brilliant. If we move on a bit, then actually the journey of breast surgery was from some fairly barbaric medieval instruments to the Halstead mastectomy, but as time has gone on, then we did what I would call an open-plastic mastectomy, and then actually thinking about complex reconstruction, so females really can't tell that they have anything done at all. And the journey about breast cancer treatment is a long and complicated one, but it starts off, if I was to take you to the British Museum in London, I could show you a house in Paris in which a woman with a breast lump is sadly told that there is no treatment, and then actually the development of treatment with the surgical advances that we've talked about, and then more recently targeted chemotherapy and agents to specifically treat different subtypes of breast cancer. And this was our team in Belfast pre-COVID when we were allowed to stand and see each other without masks, and we were pretty smart sort of acknowledging that we were doing complicated stuff to try and reconstruct patients with breast cancer as well as we could. But the issue is that as the complexity of what we're doing increases, so does the risk of complications. And we're in a journey where we've traveled from a 40% 5-year survival to now an 85% 10-year survival with a diagnosis of breast cancer. And so what that means is the issue of survivorship becomes so much more apparent. In the days of Halstead, we shoot the surgeon's hand afterwards, just like they did get it through the operation. Whereas now, at the point of diagnosis, I'm telling them, you need to think about what you're going to look like on your beach holiday in 10 years' time. But this is the thing that sort of strikes fear at the heart of any surgeon. We're looking at it like, well, that could go one of two ways, couldn't it? It could either have extra ways, or it could start becoming more and more problematic. For breast surgeons, and the first question is trying to find out the data. What are the rates of complication? Because if you chat to any surgeon, most of them don't have any complications, which is strange that we have to have these women management conferences and so on to deal with them. But the best way is to look at what data that surgeons haven't collected. And in the UK, there was a mastectomy and breast reconstruction one, which was just looking at the rates of complication. And essentially, the headline rate is that mastectomy, a simple mastectomy, the complication rate is sitting at about 10%, having a major impact on the life of the woman, but also then the service and their ability to get all back to work. Again, looking at why there are excisions and mastectomies, these are the smallest, simplest operations that we can do to treat any breast cancer. And again, the rate of complication is sitting at about 10%. The question, of course, is who are these folks? So as Thomas again was saying, is if we want to sort of think about rehabilitation for anybody undergoing an operation, but there's stuff that we can't change. We can't change their BMI if we're wanting to operate on a cancer patient in a couple of weeks. But we can think about stopping smoking, we can think about operation duration and all those kind of things, but also recognizing that an SSI does have an additional cost in the UK environment. But the thing to remember is that this does have a significant impact on the patient. The patient has gone through the psychological trauma of being diagnosed with breast cancer. They're then having to think about which operative procedure they want to undertake, and then after all of that, they say, well, it hasn't gone according to plan, and now the treatment course has changed where you're going to have a whole new set of visits to outpatients, dressings, and things like that. And of course, the thing is to remember that these are cancer patients, so the surgical aspect is only one part of their treatment. They can go on to think about chemotherapy and radiotherapy, and any surgical site infection has the potential to delay that treatment and ultimately impact on their overall prognosis and survival. So what do we do with that? Again, not just thinking about sort of mastectomies and wide excisions, but thinking about free flap reconstructions or implant reconstructions. Again, all of these things, the mantra is that increasing complexity as they bring in an increased risk of complications. And these are the things that we don't want to see. These are the things that are going to cause delays to people getting their chemotherapy and their radiotherapy after their cancer treatment. Again, the question is well, as we've all said, if you chat to surgeons, they will say that they don't, in their hands, they don't have any problems, but let's look at the data. This is the UK team study, which was looking at therapeutic mammoplasties. That's essentially where you do a breast reduction as part of the cancer treatment. And this was at 880 patients throughout the UK and treated in 50 centres. And why are they being done? Why did we do this with slightly more higher risk procedures to improve diseases, avoid a mastectomy, and allowing the symmetrization? The question is what were the rate of complication? If we're looking overall, what we're seeing is a complication rate of about 20%. Somewhere between 50 to 20% with grade breakdown being a significant factor. And again, no surprise, what are those things that you can do? Either smokers increase risk of complications, obesity, higher ASAs, the more complex the patient, the higher risk. Interestingly, surgery experience, again, was a problem, and then there's a certain type of incision that can increase the risk. Interestingly, there was a study that whether complications caused the delay, and actually there was no difference in the delay, no difference in sort of linking it to your pharmacological treatment in this study. The point though is, it's a moment when we have to reduce the we have a problem. If we're saying that 1 in 4 people have a complication, 1 in 5 people have a problem around the nipple, then we have to then look and see is there something that can be done about this? Is there an intervention that can try and reduce these complications? And as we've already said about the purpose of this is to introduce you to the people dressing it as a negative pressure wound therapy as one of those options to be used. With that in mind, a sort of small observational study looked at using people dressing on the intervention side with the therapeutic mammoplasty on the other side. So these were patients who had cancer on one side, either had a therapeutic mammoplasty or a mastectomy with an immediate reconstruction. And then they can symmetrize the surgery on the other side. And so what they did was use the people dressing on the countryside, but didn't use it on the other side. And what we see already is that there's evidence that people dressing is starting to reduce the complication rate on the side that it's being used on. With that idea, then looking around and seeing if there are other evidence to encourage the use more widespreadly. These were patients who had cosmetic breast reduction operations. 300 patients had a go within there. What we were looking at is the healing issues and complications. And the beauty of this is that you can do it. It's a sort of internal control. You use the people dressing on one side and you don't use it on the other side, and then compare within the patient as to how things are doing. But what they found was there was a significant reduction in healing complications and wound weaknesses. And this was the first essentially major randomized trial within and using negative pressure therapy in patients. Again, looking at the workflow, the sort of quality of wound healing is not necessarily just about infections, but how it does look. And again, the wound complications were significantly lower, but with various sort of scores used to assess the strength of the wound and how the patient felt. And then again, negative pressure wound therapy was making a significant difference in how these wounds look. Again, I suppose we're moving on. These are cosmetic patients. This isn't the sort of horror of super talkers like Thomas is shown with stoma and wild contents leading out. But these are people who have undergone a procedure that they're trying to get to look as good as possible in the long term. And so with that in mind, these are some people who have therapeutic nanoplasties. I'm just showing you the video of what we do. This is a closed wound that we have following therapeutic nanoplasty. And then what we do is put the people dressing on to cover the nipple area and the junction. Just checking, can you start that video? And so what we're doing is having a look from a point of view of what we're trying to do is work out the areas that are most high risk, so around the nipple and the junction. And then, are you able to shoot the video just to see the people dressing wrong? Start that one. So you can turn the audio down, but just to say, so what we're doing is using the dressing to cover the high risk area around the nipple, and then cover the two junctions, because this is where the blood supply to the wound is the most limited. And what you can see is that looking at the calculations who had this done, these are people who had the therapeutic nanoplasty. These are their wounds at so 1 week post-op and then 3 months post-op. So these are people who, in essence, you're looking at this and going, it's hard to tell that these people have had any operative intervention. The question then is, where one of the most recent advances in breast reconstruction after breast cancer is thinking about prenatal implant reconstruction. Historically, implants were put in submuscularly, and that meant that you had a large depth with good blood flow supplying your muscle that was between you and the outside world. What we're doing now in prenatal implant reconstruction is putting in the implants, but what we have is just an ADM, a cellular dermal matrix, which is this white structure here. And then what it is essentially at a depth of about 3 or 4 millimeters between the implant and the outside world. And this is exactly what I was saying earlier, is the more complex the surgery, then the higher the risk of complications. So the question is, that we wanted to know in our study was looking to see whether negative pressure wound therapy will improve the wound healing in this higher risk complication. And the thing is, again, implant reconstruction, like it was wrong, is an absolute tragedy for the woman. There's a scarring, there's the increased frequency of coming to an outpatient appointment, but also it's the tragedy of somebody who wanted to leave hospital with a reconstruction in place, having to deal with their flat chest and the whole psychological impact of it. So, what we did was undertake a study where we looked at folks who had undergone negative pressure wound therapy, but also was found in cohort
These were a similar population, but all had gone through the same kind of procedure. But what we wanted to look and see was what were their outcomes of this. There was no real difference between the things like length and minor complications, but the big game changer was that there was a significant difference in wind breakdown and implant loss. And of course, we shouldn't be surprised by anything. The length of wind now, it's a depth of 3 or 4 millimeters between the outside and the implant. If there's any form of wind breakdown, then implant loss is a real possibility. The question though is what are the cost implications of that? Never mind trying and outcomes, another piece of again, all of which will cost thousands of pounds. The total journey can have really quite a significant impact on the financial representation. Or what we saw was if we just talk about reconstruction failure, it is a significant cost saving. But actually, if we're looking at lots of reconstruction failures that are avoided, then actually the cost saving multiplies up and really is quite a significant factor in this. But that was just our study. What's interesting is people have caught on with this idea. There's more systematic reviews being undertaken. This is a collection looking at 10 studies with 1,230 breaths. And the big sort of headline is saying that actually negative pressure gene therapy is a promising option with beneficial results because it's reducing the overall rate of liver complications and respecting necrosis. So in a wider range of studies, this is making a significant difference. The question though, when this comes back to the heart of it, in cancer patients where we're trying to treat them well, not only to have a good outcome cosmetically, but also to treat their own quality. The question is, does it make a difference? And the IGRAD 2 study, again, on a UK-based study, looking at results across the UK, recruited 2,540 patients with different forms of reconstruction. The interesting thing was that there was no significant delay between the reconstructive type. So whether you had implant-based reconstruction or free flap reconstruction, but the thing was that if there was any form of complication at all, it did lead to a significant delay in you getting your oncological treatment. Again, the question to that, looking at implant-based reconstruction on by itself, then the question is, does that have an impact in the long-term outcomes for the ones that were treated? And this is a slightly terrifying study that was undertaken in the West environment. When what we looked at was their implant reconstructions, the infection rate, but the worrying thing was that the 5-year survival rate for patients who had hard-wind complications sat at 64%, but those without wind complications sat at 89.3%. So if we look at the Kaplan-Meier curve of that, actually the certain site infection was having a significantly detrimental impact on the overall outcome. Again, thinking about whether we can intervene in that, whether we can reduce the surgical site infection, then actually from an oncological point of view, we have achieved to intervene. And so I suppose, as I draw to a close, what I want to say is, in essence, when we're thinking about the sort of time that takes the negative pressure wound therapy addresses alone, thinking about in COVID times reducing the brief level of patients in the hospital and things like that, actually what we have is an intervention, just over £100 or $150, that can not only reduce the risk of complications of the wound, but it can have a significant impact on a cancer patient's journey and overall prognosis. The question is, why do we not use it? Many thanks. Thank you. I'm going to close out this session just with some reflections on how we take some of the insights and practical experience we've seen in surgical practice and translate those into evidence-based guidelines. And we've seen some excellent examples today on how single-use negative pressure is being used to run complex moves. And we recognize that this therapy has enormous benefits, but needs to be used appropriately. So
So I want to share with you today some thoughts about how we use health technology assessment and guidelines to position this therapy for the most appropriate use. Some of you will be familiar with this. I come from a different world to many of you in the room. I'm not a surgeon, I'm not a healthcare practitioner. I work in health economics and health outcomes research. And our currency is really health technology assessment. We want to look at what clinical benefits and what economic benefits the technology can provide to the healthcare system. And this is a method that's becoming more prevalent across the world right now. For many reasons, we see demographic change driving increased demand on healthcare, more chronic conditions coming to the fore, changing technology, as you've seen this morning, but also patient expectations increasing. Patients are expecting access to new technology, they have more knowledge about new technologies. And then recently, of course, we're also seeing emerging pathogens which are creating more pressure on healthcare systems. So around the world, we have healthcare providers, healthcare payers, looking at how they're going to justify the use of new technologies and position new technologies for appropriate use. And that's really where health technology comes to the fore. And this is widely prevalent. Many of you will be familiar with institutions who work in this space. Some of them are government institutions, some of them are organised by insurance companies, and some of them are academic ones as well. But you see a few examples here. In Australia, we have bodies like the Medical Services Advisory Committee, which is very focused on medical technologies. In Canada, we have very experienced researchers working in this space in Canada. And then increasingly in the US, we have bodies like ECRI, AIMS, and the ISA Institute, which are all trying to promote this methodology across the US as well. So a very experienced body of researchers working in this space. One of the most well-established bodies working in health technology assessment is the National Institute for Health and Clinical Excellence in the UK, typically known as NICE. And I suspect many of you may be familiar with NICE guidelines. Although it's a UK body, their impact tends to go global. They do have an impact in many other markets in many other countries around the world. And they do a range of different technology guidelines, clinical guidelines. So they provide guidelines on best practice, but they also look at high-cost technologies, be they pharmaceutical technologies or medical technologies. They look at diagnostic technologies, very relevant recently, and also they're looking into the status of digital health as well, which is their increasing focus for them. And NICE's role is to really evaluate the clinical evidence that's available on technology, bring them together with the economic evidence and determine what the appropriate use of technology is. In the most extreme cases, they can recommend that technologies shouldn't be used because they're not considered clinically or cost effective. In most cases, they will recommend uses in some limited populations where we can achieve the best results from using the technology. And they turned their attention to single-use negative pressure wound therapy a few years ago and started to look at producing medical technologies guidance, which would provide advice and guidance to practitioners in the UK NHS about how to use this technology in making certain decisions. And it's a pretty rigorous process that they go through to generate this evidence and generate the guidelines. So they start by working with a company, the manufacturer, in this case, to look at the technology. As a manufacturer, we submit evidence, but they also commission an external academic group to generate evidence as well, who undertake an entirely independent assessment of the technology. And then they bring all that evidence together to produce a draft guideline, which goes through a review process with manufacturers, but also with people like yourselves, with healthcare professionals. And they advise and take input from healthcare professionals throughout this whole process, resulting in guidance which goes out to the health service. I'm not going to go through the whole document, it's a lengthy document, as those guideline documents are, but I want to pull out the key headlines for you here in terms of their recommendations on the use of single-use negative pressure. And I want to just put these in three different categories. So the first one is around clinical evidence. Secondly, I want to talk about patients who are eligible for this. And thirdly, I want to talk about the cost. So looking at the clinical evidence, they did find that there is a significant body of evidence to support this technology. And unusually for a wound care product, we have multiple high-quality level 1 studies to support single-use negative pressure wound therapy. At the last count, I think there are 15 randomized controlled trials available on this technology across a range of different surgical interventions. Now, I think many people in the room will recognise the challenges of conducting randomised controlled trials in wound care. So that is a real step forward for generating that volume of data. Having looked at the data, they suggested that single-use negative pressure therapy is associated with fewer surgical site complications, and particularly infections and seroma compared to standard wound care. They also recommended that it's best positioned for use in closed surgical incisions in patients who are at high risk. And you've heard from some of the previous speakers about the risk factors which may elevate the risk of surgical site complications and particularly infection. And thirdly, they found that the additional clinical benefits that are provided by video dressing are provided at a similar overall cost to standard care. And you heard in the previous session that prevention can often be a cheaper method than curing this indication. Some of these complications can become very challenging, very complex to manage, and they can take many months, if not years, to resolve. So early intervention and prevention can actually be a cheaper option to manage these groups. And briefly, I'll take you through the evidence which was used to come to each of these conclusions. So if we start with the clinical data, as I said, there is a significant body of data out there. I think 15 randomized controlled trials, multiple observational studies in case series, and there's a couple of systematic reviews which have been published on this. So I think Professor referenced this Gala analysis which was published. We recently updated that, and there is additional meta-analysis including some more recent studies which we published over the last 2 years. And in this, what we try to do is to combine the full body of evidence, conduct a systematic review and conduct a meta-analysis to see what the overall impact of dressing is. And what we found is that there is a 63% reduction in surgical site infection associated with the use of the single-use negative pressure therapy. Not just surgical site infections, but we found a range of complications which also improved with the use of this therapy, and in particular, we found a significant reduction in the rates of dehiscence. And as you saw from the previous speaker, one of the key issues here is not just infection, but also dehiscence and the long-term management and resolution of dehiscence that may occur in surgical wounds. So a significant body of clinical evidence and all the indications seem to be pointing towards a very positive contribution to outcomes. This evidence is valid across multiple different indications. Now, one of the challenges that we have with wound care dressing such as this is how do we generate evidence across multiple surgical specialties. But we're in a fortunate position that we have studies across multiple specialties, breast surgery, which is but also cardiothoracic surgery, orthopedic surgery, obstetrics, notably C-sections, where there's very strong data, and vascular surgery as well, general mixed surgery data as well, we have mixed cohorts of patients. And the good news is that reduction in surgical site infections and surgical site complications seems to be reproduced across many of the surgical incisions. And we recognise there may be different variables across patients with those indications, there may be different risk factors, but we are seeing that consistent improvement in outcomes. I mentioned risk factors as a second point I wanted to touch upon, and the evidence that was reviewed looked at subgroup analysis in risk factors. So they looked at variables in patients which might lead to either elevated risk of surgical site complications. And I think for many of you in the room, you're probably not very surprised by the risk factors that were identified. These are risk factors for surgical incisions, but also in many cases for chronic wound management as well. So we found that there were patient variables such as presence of diabetes, and also BMI and obesity were associated with a higher risk of surgical site complications. From a surgical perspective, though, we did also find that surgical risk indices like the ASA score, higher ASA score associated with greater risk, as was emergency surgery. And from a UK perspective, about 15% of patients were admitted for emergency surgery, and these were associated with a higher risk. So, in these patients, there is really strong data of even greater clinical efficacy for using single-use negative pressure therapy. And the final point I want to turn to is cost. Very close to my own heart, this is an area I spent my life working in, but I think increasingly we recognise that although therapies may provide a significant clinical benefit, we have to prioritise how we use the available resources. And in some cases, that means targeting therapy to those patients who can benefit most. So we've talked a little bit about the risk factors. That's one way we can do this. The other way we can do this is through using health economic analysis. And I think a couple of the previous sessions mentioned some of the health economic studies we've done in this space. We published cost-effectiveness studies across multiple surgical specialties now. So C-sections and obstetrics, orthopedics, we talked about joint repair, plastics and breast surgery, and also cardiac surgery. And similar to the clinical evidence, the good news here is we see a consistent trend. In each case, in each specialty, we see that the single-use negative pressure wound therapy is delivering improvements in outcomes, but it's reducing the total cost associated with managing these patients. So although there is an incremental cost associated with the device, associated with the use of negative pressure, we see that the actual cost of managing the patients is reduced because we're having fewer hospitalizations, fewer readmissions, fewer long-term sequelae that are associated with managing the surgical cycle of patients. And you see the recommendation here from the NICE committee and the NICE guideline, which suggests that cost modeling of the PICO dressing provides extra clinical benefits at a similar overall cost. So this was not considered to be a cost-additive technology. It would either save money or, at the worst case, it would be cost-effective to standard therapy once you take into account the overall treatment cost. So just to summarize, I think the PICO dressing is supported by unprecedented level of clinical evidence. As I said, there are very few wound care interventions that I can think of which are supported by such a significant body of evidence and particularly level 1 evidence. As I reflect on it, compression therapy is probably only one of the other few wound care interventions I can think of which has such a significant body of randomized controlled trial data. So there's been a significant effort to really try to illustrate the clinical effectiveness of this technology in close surgical decisions across multiple surgical specialties. The good news is that we're not just taking from me, we have independent analysis and independent evaluations on bodies such as NICE in the UK, which suggests that the dressing can provide improved clinical outcomes compared to standard surgical dressings. They also suggest that it can do that at a comparable cost to standard dressings. I know all healthcare systems around the world are sensitive to cost, and we recognise that when you look at the incremental cost of a single-use negative pressure dressing compared to a standard surgical dressing, it looks as though there is a significant cost associated with it. But what I would urge you to do is to think holistically about the overall treatment cost of managing these patients. If you can do that, then you will see that the overall cost is comparable between the single-use negative pressure dressing and standard surgical dressing. In addition to that, I think we would also endorse looking at how best to utilise this dressing and which patients are most eligible for it. So we recognise this dressing may not be appropriate for every surgical incision. Low-risk surgical incisions with a modest risk of infection, a modest risk of complications such as DSS will continue to run with standard surgical dressings. But you've seen earlier the clinical case for trying to manage these complex surgical interventions. And we would recognise that there are risk factors associated with surgical closed incisions which might provide further justification and allow you to target resources to ensure that single-use negative pressure is used appropriately in the right patients at the right time. Thank you very much. Let's invite our speakers back up onto the stage.
I will just show shortly, because we want to spend some time for discussion for question and answer. What can happen when we don't make a prevention in very relevant situation, and how can we introduce this information in clinical practice? It's a COVID time, COVID patient at indoor hospital, very obese patient with severe problems and with huge pressure. There was totally deficit. That's exactly what can happen when the system is dysregulated. The patient spends a lot of time in the surgical ward without specialization because all the surgeons was moved to the COVID centers. It's a real life, it's 1 year ago. And how we start to make operation with this patient, first it was very complicated intubate the patient. You cannot put it just having the ventral up because intubation and ventilation was too complicated. I need to make operation in this position of this patient, and let's look how inside. It's totally necrotic tissue. And then I was sure what I need to do. First, stabilize the situation, remove exudation, remove septic condition. So negative pressure wound therapy was a radiologic choice for me. And the question was what type of negative pressure wound therapy was used on the standard system. Of course, the size of the wound was dramatic. And you can imagine that general condition of patient was not too good. So we removed the negative tissue. We made a place, a space, just to make a resection. We found a very big intervention. I heard about the bleeding. All the tissue was very inflamed and very septic condition. So let's look. I want to show. I have evidence. Let's use negative pressure wound therapy. Flexi. So according to the tissue, I store as much skin as possible. I put the sponge inside in the subcutaneous tissue. Then I make a deeper sponge in both pockets of the vessel. I stabilize it, and I start to make a superficial wound dressing. It is not so easy to make a skilled system because of localization, because of skin condition, because of thousands of other problems. So we make it step by step. Step by step, we put first sponge outside, we put the foil, we make it sealed with the stoma paste. I like the stoma paste a lot of this localization. Then I have a half of wound. We let another part was sealed by the stoma paste. Again, the renaissance was done and that's look, it's sealed. It's French believe, but it's sealed. And we decided to put the second one wire adapter just to be sure that the system will be effective. And what was my idea? Just to get to this, because of our knowledge about how important is the mechanism of action of negative pressure wound and how important influence it has. We have after 48 hours much better situation. There is no more infection so wide around the tissue. We improve the situation. Let's say a burn between the cervical burning between after previous surgery. And let's look another dressing trend done by my younger colleagues, the residents. The situation went better, and look at the tissue. It's still not beautiful. We still make another one. We still make some improvement of the condition of the tissue, but we must look. But let's look what is the final point. We send the patient back to the hospital just to make a final treatment. No more infection, no related tissue, and we know that the scale was maybe not beautiful that the patient survived. Not so very dramatic situation. It's for my colleague Marco Sacaveri from Italy. The breast surgery was so beautiful before, but let's look what can be done when we make a much faster delivery situation. The small place of infection recognized easily, just negative pressure wound therapy as you see before, and the result is beautiful. It's a pulse on the wound, you see, but no more exudation in the wound, no more pulse in the breast, and what's there. I'm not the breast surgeon, but COVID time was crazy one. One patient came to me because she was operated in the hospital very far from the hospital from my city, and the hospital was changing the company this time. So the patient had a huge problem, have both necrotic lesion of implant inside. I can do not the breast surgery. So I talked with my colleagues that in 1 week, he will admit the patient to the surgery. He said, please do something to improve the situation. So, okay, let's improve the situation from the beginning. 24 hours, university. Then stabilize the exudation. Then again, the wound dressing, because after neck rection, the exudation was a little bit bigger. You can see how exudation was effectively drained outside from the both breasts. Then the exudation in this one was bigger, and then settle the situation. It was not very beautiful once again, but I stopped the septic condition, I stopped the deep infection of the tissue, then I sent the patient, and in this patient, this implant was removed, this one was spared, but generally the local condition of the tissue was not so bad. That's a patient, not asking about the reason we are in the patient in this condition. The patient with multiple fistula after 12 laparotomies, and he decided to make nutrition, but the whole of the patient was so big that the patient had stomach, duodenum, small intestine and big intestine and the large intestine open, and daily secretion was about 3 liters of fluid, of the stomach fluid, of the pancreatic fluid. So we decided that only one way for this patient, the mortality rate for this patient was about 85%. But when I don't operate this patient, the mortality will be 100% in the next few days. So we decided to make a sample to remove all the infected tissue around the fistula together with all fistulas. It's deep abdominal surgery. I reconstruct the tract in few places. I make an anastomostic dissection. Very dangerous situation in this moment because of condition of patient. I make 4 different anastomoses. And I close down. I have no in the moment, because I'm in hospital, there is not a rich hospital in Poland, we have no reimbursement of this method. You can ask me when we use it, because it worked. With the bone shown on the previous slide, it worked. But the next, it's a technique, just close the tissue, to close that level. Then, the healing was not so bad, and you can see that what happened, fistula. It's really very dramatic. No, it's bad. Because I was believed that so long that I will keep the abdomen closed, and I will have only one fistula, we can save the life of the patient. We keep the enteral nutrition from this patient. We use the method of healing of secondary complications, so such as infection of the early stage, and look at the results. It is after suture removal, seems to be much better, and it's after 3 weeks. And it's all done by the keto localized in this existence of the wound in septic condition. The abdomen is closed prior, and the fistula, small intestine fistula, was cured. You can see on this example, and that's the condition of patient after the surgery. The patient was happy and said, I'm so strong in this situation. So the picture was done because of patient condition. So the question is about decision. What type of negative therapy we should use? Simple means, I like it very much. And always when we have a trouble, it can be treated by simple means. Let's do that. That's very strategic. Just keeping the time. The orthopedic surgeon asked me to help, and I need to explain. The patient had a resection of left leg with half of the pelvis. So I need to show the incision line was like this one. So the half of patient was removed because of sarcoma of the femoris. And they asked me 10 days after surgery to help. What we see here, here's abdomen, here there are intestines, here is urine bladder, here's a sacral bone, and ducal bone. Dramatic situation of patient. What is our idea first? Always when you see the wound, I have in mind, try to close it. Try to make a primary closure of the wound, maybe not in the moment, but avoid to keep it open very, very much. I know that's the granulation, that's the opening of the wound in septic condition, is still the strategy. But we have negative pressure wound therapy, and we have our knowledge to make it better. First, of course, is big story, because the patient should have a stomach. I said that the stomach will be for the patient the worst scenario. So I checked that the patient has 10 days notification. So first we make the regular entry from the stool just to make an intestine normal condition. Let's look what we do as the next stage. Everything is a really infected tissue. I make the tracheotomy 2 hours only with scissors because the patient has a huge blood coagulation problems. I avoid of bleeding, and then we put sponges deep into the tissue like a sandwich technique, and then I close the tissue above the sponges. So the sponges was localized very deep into the sacral bone, and it was the first stage just to make stabilization of the tissue. You can see venousness, you can see the fluid with instillation going through all the wound and going through the sponge to the venousness. But you can of course see my tapes because I like the tapes. They improve the very complicated tissue, the healing process. And let's look how it works after 4 days. Much better, much less necrotic tissue. And we start saying, okay, let's try to close the wound step by step. All time keeping negative pressure inside. Just making evacuation of exudation and trying to connect tissue. Make the tissue healthy, connect the tissue. Because step by step procedure, and with a lot of sponges, you can see, for example, here the white sponge, which is done on the intestine. then I make a temporary suture, then I make again negative pressure wound therapy deep inside and above, and of course on the relapses with the choice. That's a much better situation in this one. And I continue, it's not so simple, because during this time you recognize, you see the tissue inside, it's beautiful, but you can see, for example, that the ureter is destroyed. I make a reconstruction of ureter by the injected tube because we work a lot on the pelvis, so we make also the urological supplement. And you can see what was the next step. The next step was just closing the wound again and again and again. Just the part of the wound was closed, and we hope that is the final closure of the wound. Still negative pressure. Let's look how the sponge looks. We create some different shapes, different forms. It's like a snake, we put it deep inside. We make a format according to the wound size and wound condition. Again, negative pressure wound therapy because again takes, and it is a level in which the patient will discharge to another hospital. And it is a beautiful moment to put pico and both this granulated tissue and be ready maybe for skin transfer or maybe just for granulation. The patient was prepared to skin transfer on this area, but you can see that all the tissue is pretty close, it's pretty in good condition, and we make for patient the chance for the therapy for rehabilitation at home. And the last case, I think, just to have the time for question and answers, it's more at my area. I am maybe admitted with critical abdominal complications after diverticulitis operation. So what to do in this case? Of course, making the damage of the tissue less. So it's mean let's see on the skin, let's see on the exudation. We decided to improve the situation locally using renaissance. I like the negative pressure wound therapy, I like the renaissance and both the fistula, improving the situation, giving the potential for patient to make operation. Once again, operation like the previous patient, I remove all the fistula openings outside, then I remove all the part of bowel movement sleeve. I was very happy because it was only altogether, it was just about 80 centimeters of small intestine. We make a very good connection, we make the continuity of GI tract, and we decide to close the abdomen triangularly, just with small breathing, and of course, in this case, to avoid of cervical side infection in this case. The cervical side infection for this lady, or of this lady, with a very severe condition will be very bad. So we do, of course, in this case, because prevention of cervical side infection. You can see how it works. Not bad. We sometimes work in the patient with enteral nutrition. It's come so far. There is a pool 3 months ago, and we make a liquid dressing. We discharge the patient. The patient was discharged before the Christmas, and the patient came 2 weeks ago to control. Listen, there is no distance. There was no cervical infection, or maybe better to tell it was a first degree of cervical infection. And the patient is ready to be prepared to close the stomach. The patient now knows about improvement. By the way, the patient knows that we will have 9 months to do that, and the patient of course knows that the pickle will be put on the wound after the restoration of GI tract. But I think maybe the patient should accept the stomach. The patient is afraid about home operation, the stomach will be well. So we know about how prevention is important. I have a pleasure also to work with colleagues with UK just to discuss in the commentary how important it is to improve the healing of the wound on every level. And like you can see, using the single-use negative pressure wound therapy should be considered in every stage, from surgical treatment, outpatient, post-surgery, outpatient, wound care. Always is the choice, I think, very good. Traditional systems with a big one, depending on the situation. Of course, in hospital, sometimes like this is necessary, but in many cases, it's also very effective. And the story of patient, I like to show the patient as soon as possible. The patient has a computer system, very simple information he wants to do exactly really well. And it's SMS for patient. That's the patient said that from the beginning it was some problem with sealing, of course it was in Polish and translated. But the patient knows that it's good to push a little bit more pressing, and you can see what we have here. It's nice wound with stomach, and here is a wound dressing. They protect the wound from secondary cervical infection, And I hope it was a good choice for patients because patients should be operated in hospital, but should be back to his good condition at home. So thank you very much, and if you have a question, we are here, as well as on the roof of Smith and Heavy Company, as well as tomorrow at 11 o'clock. We have also pleasure to make a workshop.
Thank you, Professor Zivich, and thank you, Dr. Irwin. We have a few moments for questions, if anybody has any questions, and I know there's a pressing issue of a prize draw, which I will get around to as well. But I'll open up the floor for questions, so anybody wants to come forward? Everyone's being very shy. There you go. Yeah. So absolutely, if people don't feel comfortable raising questions in here, then we will be on the booth. I think that's about to see lectures on tomorrow on the booth session as well. So call Pastor Smith and let you booth if you like, and we can address any questions for you in there. Last chance for any questions before I move to the prize draw. Oh, we have more.
My name is Muhammad, I'm also very good. To get using the eco basic, if I can get inside.
You just repeat the question?
I am working in orthopedic. If I have traumatic wound and we have open wound, we can get inside muscles and tendons. You can use eco bracing or go direct for fracture.
Okay, so once again, just you can use PICO? Yes, you do, of course. Because you know what is the benefit. If you are not sure about how it will be work, with PICO you will never disturb too much. Because the worst scenario is that the excitation will be so huge that you will change it faster. But I like to make it as a check strategy because it's very soft and safety for the tissue, and the silicone layer make the protection grow the tissue inside. So I think this is absolutely correct.
It's just to say as well, you can't use the PICO dressing with a black sponge. So it's often a level of like skin, whether you need to use a formal system, like a Renaissance, or whether you can just use black sponge to fill in the defect. And the PICO dressing, again, the larger the PICO dressing, the more evaporation you get from that. So actually, there's a good data that you're improving the blood flow to the wound if you put a much larger dressing on, but also that helps with the evaporation, so you can sort of mix and match it.
What is the tricky, and I was there maybe very late, but like you know, surgery was to get a long time to learn. That's when you connect it with next pouch and when you have a big exudation, you need to localize the port of the PICO as far as possible from the next pouch. Because if you put it above, you will have a private exudation in the tube and it can go fast in the pump. So when we use all the filler in the PICO, we will talk about it tomorrow on the step. How to do it? Just in connection, try to make as long as possible the distance between sponge and the port of the tube.
Thank you. Any additional questions? Okay, just thank our speakers once again today for an excellent session. I think some super insightful, incredibly complex cases in this year, so one last day before we go. Marissa, I just remember, is it 10? 10? Thank you. I bless you both. Completely independent from system that you should see now. Okay, so raffle draw. Anybody who has these numbers, please go to Smith and Nephew to collect your prizes. So the numbers are today 0032. Oh, this is exciting. This is like a lottery. I'm very excited. 0042, 0107,
Awesome.
please, 0125, 0124, 0208, 0209, 0210, 0214, and the last one, apologies, 0215. So anybody lucky enough to have those, please come to the slip connecting group. Just thank you all for attending today. I hope you found this helpful.